Good morning, everyone. It's 10 o'clock, so we're going to get started. Thank you all so much for joining us for the 9th Annual Communication, Apology, and Resolution Forum, hosted by MACRMI and the Massachusetts Medical Society. We want to offer special thanks to the Coveris Community Healthcare Foundation, who sponsors this forum. We are so grateful for that because we know that this content is really important to you, and that we're so grateful that they support this. As we noted before, the session is being recorded. You can send this to other folks later. They won't be able to get CME credit, but everything that we do here today will be recorded so that others can see it later. Please do not unmute yourself or turn on your video. If you have any questions or comments for the speakers, you can just type them through the chat box. So let's get started. As we mentioned before, our forum is going to be split into 2 parts. Today, we're doing the virtual part with our keynote speaker, and our live part will be happening in hopefully the spring. We're going to be doing some simulations like we usually do of different cases and how to process those through the care process. So for today, there's just this single objective. There are no disclosures. And if you would like CME or nursing credit after this, you will receive a link as long as you registered. If you didn't register, please make sure you do that. You'll receive a link with an evaluation. And once you complete that, you'll get a CME certificate. If you are a nurse and want nursing credit, you can just email me when you're done with that evaluation. So today we are really excited to bring you this forum. We have folks from around the country. So I just wanted to do a quick overview of what the Massachusetts Alliance for Communication and Resolution Following Medical Injury is. We call ourselves MACRMI, and we are a group of all of these organizations here on the left side of the screen. These are organizations that really care about making communication, apology, and resolution the primary way that adverse events are resolved in the state, and it's our mission to make that so. And so we all work together to make that happen. Today, we're going to do a quick background on what communication, apology, and resolution, or CARE, is and why we use it. I know there are some folks that are new to this concept on the call, but also for those of us that have been doing it for a while, it's always nice to get a refresher on exactly what it is and why we're pushing towards making this happen throughout the Commonwealth and hopefully the country. We'll review some published data, and we'll talk about a few recent MACRMI activities. Then we will go to our keynote presentation from Dr. Alice Coombs. And we also are very privileged to have a family member on the call today, Lisa, and she will be talking with us with Dr. Coombs as well. And then we'll have a discussion session after that with our MACRMI co-chairs, Pat Folcarelli and Doug Salvador. So briefly today, communication, apology, and resolution. What is it? Why do we use it? How do we know that it works, and how can you get started? Communication, apology, and resolution is not just what we would call disclosure. This is when this concept was first developed. It was sort of, okay, we're going to disclose. This is important for us to talk about these things. But this is really a program that is comprehensive. It's a comprehensive way to respond to adverse events when they happen. So first, we communicate empathetically with patients and families when unanticipated adverse outcomes occur. So that means as soon as we know, we are proactive in communicating with the family about that and providing for their immediate needs. Then we importantly investigate what happened, tell the patient and family we will do that, and then explain to them what's happened once we found those root causes. Also, very importantly, we want to implement systems to avoid recurrences of these incidents. So one of the big reasons why we do this program is to improve patient safety overall at these facilities so that the next patient that comes in won't have this same kind of event happen to them. And where appropriate, and in our case, that means when the standard of care was not met and that caused the patient significant harm, we formally apologize, take the blame and fault for that, and work towards resolution proactively, offering fair compensation without that patient having to file a lawsuit. Resolution can also include things besides compensation, and that's something that we want to consider as well. But the important piece of this is that we're proactive in trying to resolve that and making the patient and family as whole as we can. So why do we do this? Now, everyone here at MACRMI would say this is just the right thing to do. It's what your grandmother would have taught you to do. It's what you would want if you were a patient. But there are also lots of well-documented reasons to do this. It is better for patients, providers, and the healthcare system rather than the old deny and defend model. Patients and providers are able to preserve that patient-provider relationship through healing and apology, being able to talk about the event, being able to ask questions and get answers and not feel like things are being hidden. Those are really important to the patients and providers. It also helps reduce the feelings of anger, anxiety, depression in both of these folks. It also helps when patients are able to get compensation more directly and quickly. It also helps providers not practice defensive medicine. And it helps our healthcare system because, as I said before, it improves that patient safety and it reduces costs and it makes things better and safer for everyone involved. I wanted to emphasize this data. There is a lot of data on these programs, but this data today is going to be especially important because of our keynote speaker and our family member that will talk about these experiences. The Betsy Lehman Center put out this report in 2019, and this piece is really important for us, which is to show the difference between those patients and family members that received an open and honest communication after an adverse event and those that did not. They were able to survey these patients, and the blue line there on your screen is those that did receive something like a care program, and those in the orange line did not. And you can see that the outcomes of feeling abandoned and betrayed, sad, depressed, angry are all significantly higher in patients and family members that did not receive any kind of open communication and apology. Also very, very high levels of avoiding the doctor and facility when they did not receive that. So you can see even in the data that this makes a difference, even though we probably know this already as patients and family members. This really helps us to see clearly what impact using a program like this has. So how do we know that it works? That's one piece that we just showed you. In Massachusetts, we did a pilot study over 3 years where we collected lots of different institutional level data, case-specific data, and survey data from providers and those that use the program. And these are the sites we collected it at. There were 6 sites, and intentionally we used a variety of sites. So teaching hospitals, community hospitals, those that had external insurers as a medical malpractice insurer, and those that had captives, different sizes. And that was intentional. What we wanted to do is to see what would happen if we used this program rigorously at all those different sites. And these are the conclusions. So claims did not increase, even when the program was used rigorously in all of these different sites. There were no cost increases and some significant cost decreases. In some other facilities around the country, they had even larger cost savings. For us, we had a shorter study time period, so we didn't show quite as much, but there were definitely no increases, which was a huge success. So that means that hospitals and other facilities can do the right thing without increasing their liability exposure. So they're really, the conversation now needs to move to how can we do that? We don't have to worry about these other liability exposures, like will our claims skyrocket? Will our costs skyrocket? No, we've been able to demonstrate that in multiple different settings. And overall, providers were very supportive of using this kind of program when they were involved in something like this. One other big piece that we studied was, if this works, why did it work and how can we replicate that? So these are some of the things that we found were successful pieces of the implementation. So one, you need deep engagement by high-level physician champions. That's really important that the high-level physicians are on board with this and can help motivate the rest of those in your facility. That you have strong buy-in from your risk management team, that they feel like this is the right thing to do and are ready to shift the way they do things. That you have practical support by project managers, that's particularly in large sites, just so that you can make sure that you get every case every time when you're looking at your adverse events. That there are no barriers erected by your insurer. Of course, your insurer has to be a very strong partner in this. That there is a pre-existing just culture commitment. That means that at your facility, those that work there are willing to report adverse events when they happen, that they don't feel like they're going to be penalized for doing that, and that they know that the purpose of it is to improve patient safety. And finally, it was the sense of community and support from MACRMI that helped these sites feel like they could be successful. And so we're going to talk to you a little bit about how you can get started and use MACRMI to help you become successful as well. So in this state, you get free implementation guidance by members who have built care programs from the ground up. So if you want to participate in MACRMI, that is what we do. We have a implementation program that we can help you get through. We have free tools and resources and assistance using them, and we can help you get from where you are today to having this program in place, using it on all of your adverse events. The other great thing is that MACRMI has a community of experienced individuals from all different kinds of systems and all experience levels. So we get together several times a year and just talk through challenges and questions. And that's always available throughout the whole time you're implementing as well, which is just a really great resource because this is not something that everybody does. So it's really great to have those that have been working on it for a long time as resources. And then you also, of course, have the wider community of members involved in all the aspects of medical liability that are part of MACRMI. So if you have any questions about, how does the insurance work, or do I have a question for a lawyer? All of those things can be facilitated through MACRMI, which is wonderful. In the last year, MACRMI has been very busy. We have helped 7 new facilities begin care implementation. We've worked with some medical staff services staff throughout the state to talk with them about new NPDB reporting requirements for care cases. There's a new checkbox that can be checked to sort of delineate these kinds of cases if a provider needs to be reported, how you do that, and you can show that they've participated in these transparent processes. So we've worked on helping them create new forms and educating them about that. We have continued to educate those in Massachusetts and around the globe about the merits of care. We just recently did a presentation in Europe, so that was exciting. And we've developed 2 new resources for you. They're on the website, but we also sent them in our packet ahead of time as well. One is for clinicians and one is for patient safety and healthcare quality staff. The clinician document is more of an FAQ document where they can understand a little more of the details about care, what they should say when, what the reporting requirements are now, what maybe some of their worries are, trying to address those. And the document for patient safety and healthcare quality staff is about talking to involved providers about care. So when there is a provider that has an adverse event, how do you approach them? Tell them about this kind of process and help them to engage in that. And sometimes that can be a challenge. So we have some different kinds of talking points there, and we talk through the process in that document. So we hope you find those 2 helpful. As you know, we have a website, so I just wanted to put that up there. All of our resources are on our website, and there's lots of other content there. So please visit that if you get a chance. And so without further ado, we're going to have Dr. Alice Coombs, our keynote speaker this morning, get started. I'm going to introduce her. She comes to us by way of MMS, where she was the past president. Dr. Coombs practiced anesthesia and critical care medicine in Massachusetts for 30 years, and she's now the chair and the professor of the Department of Anesthesia and Critical Care Medicine at Virginia Commonwealth University in Richmond, Virginia. She was recently elected trustee to the Richmond Academy of Medicine and is associate director of the Medical Society of Virginia. Dr. Coombs was a member of the AMA's Commission to End Racial and Ethnic Healthcare Disparities and served as a commissioner for more than 10 years. While on the commission, she served as chair and vice chair of the Workforce Diversity Committee and spearheaded the development of the Healthcare Diversity Educational Toolkit to be utilized in different sectors of the community. Dr. Coombs, we're so thankful for you to take the time to speak with us today, and so I'm going to put your screen up. Okay. Here we go.
Thank you. I'm going to share screen. Is it good right
Can you talk a little bit louder?
Okay. How's that? Is that better? Excellent. I'll go ahead and share my screen. Is that okay? Okay. Excellent. So today I'm excited about delivering this presentation because it's a part of my DNA. I've actually worked in the area of healthcare disparities for a very long time, including serving on the American Medical Association's Commission to Eliminate Healthcare Disparity. My background is one in which I was engaged in healthcare disparities even before I actually entered medicine, because my mother was one who actually went through the neighborhood, would visit the sick and shut in, and many times I would ask my mom, well, Mama, why did Miss X have this problem wrong with her? And she would always muster up an answer, and I wasn't really satisfied. And years later, I find myself in the area of healthcare disparities. So what are healthcare disparities? So there's health disparities, which are preventable differences in burdens of disease, injury, violence, and opportunities that we have to equalize healthcare outcomes are missed opportunities in many aspects. So it is disproportionate that minorities, Hispanics, African Americans, some subgroups of Asians, Laotians, other minority and ethnic groups have worse outcomes when compared to the general population. So the health outcomes include things like diabetes, obesity, bad outcomes from things such as maternal mortality, we'll talk about later. Whereas the healthcare disparities are differences in outcomes as a result of an engagement that didn't work like it would in other groups in terms of the outcomes that are achieved once someone is actually in the healthcare system. And it also is a result of not receiving adequate preventive care as well. If we look at the Institute of Medicine back in 2002, they came out with a bold statement, and that was that disparities exist with minority populations, even when you correct for insurance coverage, even when you correct for socioeconomic status, meaning that middle class, and they specifically showed this, that middle class Blacks and Hispanics will suffer the same outcomes as someone in a lower class in a non-minority population. Disparities exist in many settings, not just with racial and ethnic, and we understand the impact of gender, disability status, and sexual orientation, gender identity, as we have seen recently data to indicate there are disparities that result in all phases of care as well. So one of the things I would hope that everyone receives from this presentation is the whole notion of you come to a situation where you were made aware that there is a disparities or a lack of health equity. I think that the role that everyone plays in this could have a scalable impact. And today I'm hoping that the 170 people on this presentation that's listening will take away several key concepts when it comes to healthcare disparities. So we're going to focus mostly on healthcare disparities. If we just focused on health disparities, we probably would be here until another 5 to 10 years discussing it. Not to undermine that, but we will talk later about some of the structural systematic things that actually impact healthcare disparities. So I think that's an important piece of this. So over the years, I've been involved with many groups, and we have divided strategically our strategic efforts into many aspects of why we think healthcare disparities exist. One is access. Well, back in 2010, we did a good job with the ACA, but guess what? Disparities still abound. And just because you have access doesn't mean you have good access. So you may have access to some services, but not to highly specialized care, or your referral is to providers who have low volume. So you're going to have a different, if it's a procedural specialist who is actually your doc and he hasn't done, 2 carotid endarterectomies in 1 year, he's doing your carotid endarterectomy. Guess what? That's access to a low volume provider, which is not good. Cultural competency was one of the things we kind of focused on early. We did presentations at different medical staffs as a part of the AMA's commission. And healthcare workers throughout the continuum within a healthcare system, whether it's the person who greets you at the door. I recently had an incident at one of the hospitals I work at where an EVS person called me, said, doctor, I need you in here. And I ran, and indeed the patient was bleeding into the ventilator tubing. And that was something that actually saved this patient's life. So every single person matters within the healthcare system. And then my passion is diversity of workforce. And I'll tell you why this is one of the key ingredients going forward that we should really look at as a solution to decreasing healthcare disparities for a multiplicity of reasons that we'll get to. Linguistic concordance is really important. I applaud Boston City Hospital for doing an incredible thing back, I don't know, maybe 15, 20 years ago, of having what's called patient navigators, so that if someone came in speaking Mandarin or Laotian individuals, they would have someone actually paired up, so that they would actually process through the healthcare system. If they had a mammogram, they would be constantly in contact with them, so that you wouldn't lose these patients to follow up. And so I think this is such an excellent example for the rest of the country to see. Advocacy is a strategy because with advocacy, we change healthcare policy, and that is a must. That is an essential part of this, where some minority populations will not have access to certain medications. They will have an alternative medication, which is not in the same class. And that's a whole nother lecture. And then biases. We will talk about biases because they play an essential role in healthcare disparities. This is a story that just rings true. It is just one of the hardest things that the people in South Central Los Angeles had to deal with back in 2007. This lady rolled into the emergency room at Martin Luther King Hospital, which is a hospital not far from where I grew up. She was in the waiting area and called 911 from the waiting area because of intense pain. She actually started bleeding from her mouth. It was presumed that she had some kind of bowel obstruction. She died, 43 years old, in a hospital from what people thought were really was a preventable illness. And when we talk about disparities, we talk about quality and safety. You know, there are a lot of time limits that we look at when it comes to practicing medicine. The average wait time in the emergency room, the average withdrawal time for an endoscopy. There is so many time-sensitive therapies, and when it comes to minorities, it seems like the time benchmarks that we've created go out the window. Even when it comes to things like strokes and heart attacks. But this young lady at 43 is suffering from healthcare disparities in that her time for recognition in the emergency room lobby was not adequate. So let's talk about a value proposition, okay? We look at diversity of the workforce, training and cultural competency. What is the value of addressing healthcare disparities? And we have to come up with this conclusion, and that is that eradicating healthcare disparities and healthcare inequities is good for the society and is profitable for the society as a whole. When we come to that agreement, and then we talk about how is it profitable, then we go on to the healthcare economics of having a large group that is totally excluded from society because of healthcare reasons, or having multiple groups that cannot function, and the workforce. It impacts everything. And let me give you an example of that. So 30 years ago, we had 4.5 employed people in this country supporting each Medicare beneficiary. As time has gone on with unemployment rate and increasing the Medicare population, because that's another piece of it, we've actually gone down, so that the burden of the people working for the Medicare beneficiaries has actually gotten worse. So now we have somewhere between 2 and 2.5 persons who are working, supporting the Medicare beneficiary on the other side. That's not good. And to that point, the Medicare Part A the solvency is threatened. Joseph Stiglitz said something that's really important in terms of wealth and wealth maldistribution. If you have 1% of the population controlling 46% of the wealth, then you have the same kind of distribution that occurs in leadership, whether it's in education, the private world, commercial, the world of commerce. What happens is you eliminate many groups from being on governing boards, actually determining the direction of where the society goes. And you get people who are just alike running operations across the board. That can't be good, because when you eliminate groups from governing structures, whether it's a hospital, whether it's any kind of corporation, you eliminate the brilliance that comes with that group. And that's what we got to understand. And I've done this lecture at UPMC, I've done this presentation where I actually say, I'm afraid that you've eliminated, I look across the room and I see all white-haired men. I said, you have actually eliminated the brilliance that comes with the rest of the groups that are eliminated from the governance structure here. And I applaud hospitals that see a value in putting a diversity guiding principles enacted that actually speaks words to putting different people that reflect the community on their governing boards. This is your argument going forward. I want you to take this back to whatever hospital you're at and say, it's not right what's happening here. You have a group of people that think the same, that's groupthink, and you will not get the diversity of ideas and the best alternative to solutions. And then next, I want to talk about something that I think is really important. And that is this whole idea of thinking out of the box. We have to think differently. One of my associates that I do the Doctors Back to School program actually had the benefit of going to a Nobel laureate dinner. And while he was there, he said, I'm not gonna squander this opportunity. He decided to go around to as many Nobel laureates and kind of interview them on a little scratch pad and ask them, what do you think the key to your success was to winning the Nobel Prize? Their response, he said, invariably, and he was able to go to 8 or 9 of them. And he said, invariably, it involved them taking a discipline that had nothing to do with their primary area of focus and research and study, taking concepts from something very different and applying them to their area of expertise. That's thinking out the box. That is actually going somewhere to another group and benefiting from the other group's ideas and bring it back to your specific discipline. That's what's got to happen in medicine for healthcare disparities. We've got to bring people who are not normally at the table to make a difference. I want to say a couple of things. You're normally hearing lectures all the time about healthcare disparities, and people will present the maternal mortality. You know, what we see is staggering. In comparison to other countries, most countries have decreased their maternal mortality over the past 10 years. United States has actually gone, the maternal mortality has actually increased from the year 2000 to 2014, and the mortality has increased by 25%, whereas 157 out of 183 countries, the maternal mortality has decreased. What about when we talk about Black women? Their maternal mortality is 37.3 within this country, almost 3 times that of white women. And recently, let's speak about the COVID pandemic. The COVID pandemic cut 3 years off of the average life expectancy for Hispanic males. For African-American males, 2.8. So this just underscores the deep racial and ethnic inequities to access of care. And we know undoubtedly this was such an important issue when it came to the pandemic in terms of people having access. But there was scarcity of all the DME, the durable medical equipment. There was scarcity of human capital, people actually working in the trenches. So that whole decision-making, who gets what when you have to choose, it was very important. Even in the very arrival of ambulances to the emergency room and where they were treated and where patients were actually triaged. I think these are all important concepts, but the value proposition has to be key. So years ago, when I talked about workforce diversity, we talked about a number of issues around minority physician. Does it make a difference in terms of minority physicians and where they go and where they practice? And does it make a difference in the grassroots? Yes, it does. So almost twice the proportion of minority graduates, okay, are practicing in shortage areas. And this was shown back in 74, 75. Recent data indicates that trend as well. I have another study we'll talk about in terms of medical students as well. So Black physicians go to predominantly Black areas. And Howard University, which is a predominantly African-American school, actually the graduates from Howard are more likely to practice in an inner city urban area. What about patient-physician racial concordance and perceived quality and use of healthcare? So it's really important for patients to understand in what needs to be done in terms of their healthcare and adherence and medications. But it's even more powerful for the actual patients to feel like I have more confidence in the system because I actually believe my physician. I want to follow whatever the management plan he has for me or she has for me. So in this study, they actually looked at Black respondents and Black physicians. And they were more likely than non-Black physicians, their patients were more likely to rate their physicians as excellent. With an odds ratio of 2.5, almost 2.5, they were actually more likely to receive preventive care. When it came to Hispanics with Hispanic physicians were more likely than non-Hispanic physicians to be very satisfied with their overall health. So this is a study that looked at medical schools and their diversity. It divided the diversity of each of the medical schools into quintiles so that medical schools with the highest diversity were in the first quintile and subsequent. And what they showed with this was, does medical school, it answered that question, does medical school diversity make a difference? Does it really matter? And so several things came out of the study. The educational benefits of a more diverse school resulted in improved preparedness of students to address a more diverse patient population. White students within the high quintile for medical school diversity were more likely to rate themselves as highly prepared to care for minority populations compared to the lower diversity quintile schools. Also, the white students were more likely to have strong attitudes to endorse equitable access to care. And lastly, the underrepresented minority medical students were more likely to plan on serving the underserved community. So the AAMC got that message loud and clear, and since has used that as a criteria when looking at medical schools and the overall operational capacity they have to work within communities. So what about the anatomy of what actually happens with healthcare disparities? So quality and safety, preventive illnesses, actual prevention and control of chronic illnesses are really important. Decision-making and biases do make a difference when it comes to acute care as well as chronic care. And then this whole issue of patient empowerment and healthcare literacy. These are all very, very important issues as we talk about the anatomy of what actually happens. Okay, so how do biases affect serious safety events? So Jonathan Kahneman and Michael Tversky did incredible work on framing and how decision-making is impacted by the frame. And so studies that I didn't mention were one in which a woman who comes to the emergency room without a spouse with chest pain is more likely to receive an antacid rather than to receive an EKG. Whereas a male who appears in the ER is more likely to have an electrocardiogram. And several studies indicate that women may present differently when it comes to cardiac ischemia, and their angina might be quite different than males, as is diabetics, which their angina may not be angina perceived by, it may be a variant of dyspnea or shortness of breath or indigestion. So it is easier to think and frame in that situation what you would say is to basically minimize the symptoms. So it's framed by what the bias that the individual who's evaluating the patient may have. And what does that bias have to do with culturally, what each of the physicians have been exposed to in terms of the perception and how people's situations may change. There is one thing that I've come to really appreciate, and that is this John Boyd's OODA loop, which is a process whereby a reaction, an end result of something results from a stage process of you observing a situation, then you orienting, saying, ah, the man has a gun. And then there is a decision, I must run. And then you make that decision. There's not a long gap between I must run and running. That decision-making to action piece, I feel, I don't have evidence for this, is too long when it comes to healthcare disparities. There may be problems on the front end of just the observation and going to the orientation. This young lady comes, who may be Eritrean, presents to the emergency room with chest pain. She goes home with Mylanta, only to return with a pericarditis and pericardial effusion and a pleural effusion. It was actually perceived on the emergency visit that the patient was actually hypotensive. And that was thought, she's just dehydrated. We'll give her Digel, or I'm sorry, I should name drugs, but we'll give her an antacid, send her home, and tell her to avoid caffeine. That's actually an actual case. So that whole process has got to be inherent with serious safety events. Is that looking at serious safety events to say, how did this process work? And it turns out in minority patients, in vulnerable patients, in poor patients, poor white patients, this whole process is interrupted. So thinking differently about, I am in this OODA loop, what went wrong with this process is really helpful and impacts your response. A week ago, I was at a public place and saw a lady who was laying flat on the ground and outside on the cement with cell phone apart from her and laying a foot away from her. And I said, I was walking with another physician. And I looked to the side and I thought, that person's in an awkward position and the phone is disconnected. There's something wrong. My bias went through, oh, could she have had a subarachnoid hemorrhage? Could she have passed out because of a diabetic? So I went over to her. She was unresponsive. I ran to, as they say, activate. She was breathing. But the same doctor that I was walking with said, I never noticed that. I never noticed her there. Called 911 and she was delivered to the hospital in an expeditious fashion. But that's how it works. What sensitivity do you have? Now that's a gross example of me thinking there's something wrong with her. And another doctor walking side by side with me saying, I never noticed her. That's an example. So this whole observe, orient, decide, and act has a lot to do with when we go from observe to orient, there's all these cultural traditions. They're your exposure. If I saw an African-American coming in the emergency room who was complaining of bone pain, I got to think differently. I can't think like the last movie I just saw where someone was a substance use abuser. And I'm thinking he just wants medication. He just wants narcotics. So that's the cultural observation. Or someone with a bad headache. You do your due diligence to make sure that the patient doesn't have an organic problem that really requires urgent treatment. So, and how you formulate your decision. is all influenced by cultural influences. So as we talk about biases, biases are key to how racial and ethnic discrimination has existed in this country. You know, if you go to another country and someone responds to you, because I'm an African-American woman, they think, oh, you must like to dance. Turns out I can't dance. I have no rhythm. Okay. I just happen to be a woman without any rhythm, an African-American woman without any rhythm. Those kind of stereotypes are harmless for me, but the ones that really matter are the ones that result in the difference in treatment. And so that the healthcare disparities, there has to be an ongoing awareness and learned behavior, habits. It has to be protocolized that if you don't deviate, whether a person is purple or they're magenta, when they come into your ER, they present with these symptoms, you go through the same format. Now, there are some times that you can do shortcuts, but why is it that Blacks or Hispanics are subject to the shortcuts? And so cultural competency actually has a lot to do with communication. And clearly, if there's a patient who appears to be sleepy in a preoperative setting, and the patient happens to be African-American, do you assume that that African-American has been drinking alcohol that morning? Or do you assume that the patient got up at 0400 to get there to have their aneurysm clip? Or do you do due diligence to really actually examine the patient to find out if you really thought they had alcohol on board? Or do you delay their case and cancel it and say, I think you had something, I don't believe what you're saying is truthful? How often does that happen on one situation versus another? So implicit bias is the subconscious following through what you really think, but you may not be aware that you're thinking differently with different groups. So some people would like to attribute the way treatment happens for minorities and poor people in the system as racism. And there are racist constructs that exist within healthcare systems. But a lot of times, if you drill down, there are some deep-rooted implicit biases that people feel justified in actually carrying out. And it is interesting in medicine. The Jonathan Kahneman and them have actually shown that in studies where physicians felt absolutely sure of the diagnosis, that as much as a third of the time they were wrong. So that happens in everyday life, but you don't have Jonathan Kahneman and Tversky doing research on you to say that's actually wrong. And that, do you make rational decisions all the time? Or is it the way the decisions are framed? I would encourage you to get the book Thinking Fast and Slow, because I think this is applicable to healthcare disparities. Culturally, if we watch a lot of movies, and every time we're watching a Training Day video, we think, oh my goodness, Denzel, the next guy who looks like Denzel Washington, guess what? He's that character. Because the movies that you see are reflecting your world and your familiarity and your learned behavior in response to that artificial world that you have. And unfortunately, many years ago, when they were what we call Black exploitation movies, there were a number of Black people to say, hey, this is going to impact us. We should boycott these movies. I had a dear friend who was working in Northern California, Hispanic, and she was a doctor, and every time she was referred to as the beaner for Covina. And it got to be that several other people took on that. But that's something that was heard in a movie, and they thought they would come back and apply that. That doctor was demoralized by that whole process. But let's talk about the heightened vigilance. So as an anesthesiologist, there are certain things that you really have to pay attention to in the operating room. You cannot discount a physical finding or a sign. if someone becomes tachycardic, you cannot say, oh, that's tachycardia because it's that heart rate's up to 140 because it's a Black person. And you know what? They're probably having X, Y, and Z issues. You don't do that. You say that's tachycardia and I got to find out why. That's the way it should be. But in actuality, when you talk about the other side of the screen in the emergency room, there's a study in the Archives of Surgery that when minority patients, African Americans and Hispanics, go into what's considered elite hospitals that are nationally ranked, under that situation, they get low volume providers. They happen to have a slot open for their surgery, for their FemPop bypass. And they think, oh, this is great. But they have not asked about that surgeon's capacity. How many surgeries does he do? Is he board certified? Has he had struggling cases? Does he have any patients you'd like to talk to before you have this procedure? And there's a ways around that you can do that even with HIPAA. But that's the heightened vigilance that should happen. We do it in anesthesia. We need to do it in surgery. We need to do it in internal medicine. The heightened vigilance is required across the board, even when it comes to African Americans. And as I journey through this life, I cannot tell you how many calls I get across country that someone says, Dr. Ellis, I'd like to know, my doctor thinks I've been having this problem with vision and I have headaches and, you know, he thinks my eyes, and he changed my glasses twice. And I saw a neurologist. I told the neurologist I'm actually lactating as well. Guess what? That patient actually had a prolactinoma, a pituitary tumor. And I said, you need to see X, Y, and Z, gave her direction, but she was empowered enough to call me and say, something's quite not right. So how do we control the workforce? Is there a way in which there's this invisible choice architect? Is there a way in which we can do that? I'm so sorry, my computer is overheated. Gotta pause for 1 minute. Okay, so I'll continue without my slides, if that's okay.
I was just gonna say, if you want to, we have about 15 minutes left, so I don't know if you want to pivot toward Lisa, but she has some time for that too.
Okay, so. That's actually a perfect transition. So a choice architect is the ability to really steer people's choices to do the right thing. And in other words, protocols are actually function in that manner as well. I just want to present a case. We'll go straight to the case because of these issues here. I do need to talk about the solutions. So roadmap to good health, eradicating bad outcomes involves healthcare workers and clinicians actually being aware. What do we do for training, implicit bias training? What do we do to create workforce diversity, not just with clinicians, but also with the governing boards of hospitals and institutions? How are patients going to function in terms of decreasing healthcare disparities? One is looking at the social determinants of health. Another issue is patient literacy and empowerment. How does the healthcare system function? By engaging diverse members as a part of their governance structure on their board of trustees, their board of directors, and to develop guiding principles that are concordant with you going to a better place of reducing healthcare disparities and actually monitoring them with data. So what about the regulatory piece? Let's talk a little bit about that. I do believe that in states where there are robust measures to do public reporting and it's confidential, that providers, hospitals and physician providers are more likely to report, as with the PCA structure in Massachusetts. And then payment reform should dovetail the end results that you would like to see. So at this time, I'm going to present a case. And the case involves a 27-year-old African-American male who actually presents to a hospital around 6:30 in the morning. He presents with a swollen tongue, and he is having some difficulty talking. He's drooling a little bit, but he's able to speak. So he's admitted to the hospital with a diagnosis of lisinopril-induced angioedema. He is admitted to the ICU. He's monitored. He's treated for the lisinopril angioedema, and he's admitted there for airway watch, just in case he gets into trouble. So, am I on?
Yep, you're on.
Okay, great.
You want me to just let me know when you want me to start, Lisa?
Okay, great. So he's admitted there for airway edema, and over the next 8 hours, he has a waxing waning course, drooling, and they tried to give him a popsicle. Between 3 and 5 p.m., he had increased tongue swelling, a little muffled speech. Between 7 and 8, he had difficulty breathing. They applied a BiPAP. His tongue was very large at this time, and because his tongue was large, applying a BiPAP actually kind of pushed the tongue into the posterior area of the what we call the pharynx, and he had increased agitation. So midazolam, a benzodiazepine, was given, and then he experienced decreased oxygen saturation. Surgical resident was called. The second-year medical resident was called. The anesthesiologist was also called, but in the meantime, he succumbed to a cardiac arrest from low oxygen. The anesthesiologist was called but could not intubate the patient. The surgical resident, in the absence of an attending, attempted to do a cricothyroidotomy. The patient's cardiac arrest resulted in some time period of CPR, but he did have return of spontaneous circulation. The ENT surgeon was called, and the patient went to the operating room to have an emergency tracheostomy. He went to the OR. After his resuscitation, a tracheostomy was performed, and the patient succumbed to this event. And prior to that, I do want to say that Lisa attended the church I attended, and a week before, when it happened at the very beginning, her sister Jackie had said to me, and I think I talked to you too, Lisa, about that her son had an event with angioedema secondary to lisinopril. I said, well, that's not a problem. I said, because many times the angioedema will go down and then we will extubate the patient. I've done this so often that someone comes in with a swollen tongue, is an allergic reaction. It's seen more in blacks, because more blacks have hypertension and more are taking lisinopril. But there are lots of people who take lisinopril and there's nothing that happens to them. But in this particular case, I said to her, it probably will go away. He'll be extubated in a few days. Follow-up Sunday, Lisa comes over and she says, they want to send my baby to the nursing home. My baby won't wake up and they want to send him to the nursing home. At that moment, I had a sickening feeling in my stomach, and I said, Lisa, you go to Brockton, I'm going to meet you there. And that's where the story begins. So Lisa, I want you to be able to talk about your feelings and just that process that we went through with the family meeting and what you felt during the whole time.
Lisa, you need to unmute. We can't hear you. Just undo the mute. There you go. Perfect.
I'm sorry. Good morning.
Oh, okay, good morning.
Thank you all for having me here this morning. Yes, as Dr. Alice stated, my son went in talking enlarged tongue, and not even a week later, he had coded. We had a family meeting because the doctors wasn't telling me anything, wasn't explaining anything to me. Couldn't answer any of my questions, but wouldn't answer any of my questions. So we sat, I called for a family meeting, asked them if we could have a meeting. It's me and my sister, Dr. Alice, and also Jeff, who was at the time just there to help facilitate and help me to understand what was going on and everything. So at that time, when we had the meeting, it was the resident, the attendant, and the risk management person that was in the meeting. They're going back and forth asking who's who and, you know, what's going on. And so like I said, Jeff, who's a lawyer, was there, and they said that they wouldn't answer any questions with him in the room. So he got up and left. And at that time, we're talking and like I said, still not getting any answers from them. Everybody's just going back and forth. The only thing that I can actually remember is the residents telling me, the attendant telling me he didn't come back after he was called. He couldn't come back because he lived an hour away. After that, I don't remember anything. After that, after the so-called family meeting, I didn't see him often. I didn't hear from him, or, you know, and my thing is just talk. If he had to just talk to me. I'm sorry. If he had to just talk to me and explain to me what happened, why did it take so long for them to intubate my baby? My baby would still be here with me today. Just explain to me, listen, this is what we did wrong. I could have accepted that because he's human. We all make mistakes. But if he had to just explain to me what he did wrong or what went wrong, I think I could have accepted it more. And this still happened in 2012, and it feels like it happened to me yesterday. I think about my son every day. My son that I lost, that should have been with me, that should be with me today. He never, you know, the resident, the attendant, they, you know, she called me on the phone and told me, oh, your son, I got a call like about 1 o'clock in the morning. Your son went into cardiac arrest. Mind you, I had just spoke with him about between 8 and 8:30, and I asked him, I said, Maurice, did they come up and check on you yet? He said, no, Ma. I live like an hour, not even an hour, about 40 minutes away, 30 minutes, 40 minutes away. 1 o'clock in the morning, I talked to him, I talked to him about 8:30 that evening. I said, Maurice, did they come in and check on you? He said, no. I said, okay. I said, well, if you don't hear nothing from them in a little while, give me a call back. He never called me back. I'm thinking everything's okay. Come to find out, my baby coded. I get a call 1 o'clock in the morning. It was raining. It was, I'll never forget, it was an ice storm. I was on the highway, didn't have enough gas in my car to make it all the way back. I'm up and down this highway trying to find a gas station. Thank God I had he just stopped me and said, Lisa, relax. I relaxed, turned to my right. There's a 24-hour gas station right there. Went to the gas station, put gas in my car, got to the hospital. When I got to the hospital, up into the ICU, they're bringing my baby out of the operating. I never got a chance to say goodbye to him. I never, any of that. They told me, I asked them, you know, they were saying, oh, he's brain dead. There's no brain activity or anything like that. I said to them, I said, so the doctor says to me, well, you need to start looking for a rest home or rehab place. I said, well, you're telling me there's no brain activity, because I was asking about them taking him down to have a CAT scan or, you know, just anything to let me know if my baby's going to wake up, is he going to be in a vegetated state or anything. He tells me, no, it's too dangerous to take him down for a CAT scan. But then you're going to turn around and say to me, I need to start making arrangements for him to go into a rehab or into a nursing home. But you just told me that it was too dangerous to take him downstairs, but it's not too dangerous to move him. These are the things that started bothering me. And like I said, then at the end, when I had to make that decision to take him off of life support, that was the worst decision in my life. To have to take my son off of life support when he could have been intubated, tongue and a medication given, and he would have been here with me today. It was just, and then he just no regards of my feeling, how I'm feeling, how, you know. Then it was the shoulda, coulda, woulda. I should have did this. I could have did this. But I don't have an MD at the end of my name, behind my last name. I don't know anything about medicine. I didn't go to school for this. You know, and it's not just what doctors are doing to the patients. It's the whole family that they're hurting. It's the whole family that they put through this trauma.
Right, Lisa. Thank you so much for sharing all this, Lisa. This has been so hard for you, we know, but it's so important for all of these folks here to hear this, that not only do we need to keep the families and patients in the front of our mind when something happens like this, so that we are honest and proactive and transparent right away. But then when we have meetings as well, that those meetings are just as important. That you can't just say, oh, we're going to have a meeting and that's checkbox, let's check that off. No, we need to make that a meeting where we are honest, transparent, empathetic, and show that we are going to make something different happen.
Yes.
So much for sharing this. Now we're going to move to the discussion session so that we can hopefully talk together about how we can not only do better in caring for these patients, but do better when something does go wrong. Because as we have all seen right now, this is really, really difficult. It's when something goes wrong and we don't address it in the right way. So thank you so much, Lisa.
You are so welcome. And thank you guys again for having me here.
Thank you. We really, really appreciate you taking the time to do this. And then we're going to start the discussion session. So we have a couple of questions that were posed beforehand. So I'm just going to ask Pat and Doug and Alice to put your videos on, please. And hold on one second. Okay. And Alice, are you there? Oh, there she is. Hi. Okay, so the three of you can unmute, and Pat, why don't you take it away?
Sure. Thank you so much, Melinda. Lisa, I don't know if you're still on, but I wanted to also express how sorry I was to hear that story. So sorry for what happened to your son, for you and your whole family. And to let you know that there's so many comments coming in for you. I'm hoping that you can see them. This group that is gathered on this call is a group that's dedicated to improving the communication and apology process and early resolution process for patients after a harm event. I want to also thank Dr. Coombs for that really enlightening presentation, but also for your leadership on healthcare disparities. And I wanted to pose a question, if I could, to Dr. Coombs about any suggestions that you have for us on how the communication, apology, and resolution process could be improved with regards to working with minority and disadvantaged patients. For example, are there questions that we should be asking patients and families during our processes that would make a difference for minority populations? Are there good questions that we should be asking about biased experiences that they have experienced in the healthcare system? Any suggestions that you have for this community who's trying so hard to improve those processes that were just described by Lisa?
So one of the things with the whole situation and the family member, thank you, Lisa, so much. You're a rock. You really helped us here. You are a rock to come here and to let people share your experience. Thank you so much. So one issue is a question that I think needs to happen over and over again. How can we do this better? And be willing to get the answer. You know, people will talk about cultural competency and how do we become more culturally competent? How do we rid ourselves of implicit bias? And I'm going to take the SAHA study and say that we need to duplicate that. Whatever group you're working in, diversify it. Get someone from the Philippines. Get someone very different. Your group is a reflection of the community. Make it walk just like the community. And when you do that, the people who are a part of your enclave of who you work with will also reflect exactly what the community is. And I'll tell you, people will be transparent if they really feel that you really want to improve in certain areas. And I think that's really important. Empowering people who think differently. I welcome a person who thinks differently because it gets me out of the rut of saying, okay, I think I know everything. No, you really need to inculcate those people. And I think the answers to a lot of the issues that are in the community are actually through engaging people on your, whatever it is, your board or whatever it is. But to ask that hard question is, how can we do it better and not be afraid of it? And take an element of your budget and allocate it to, we want this thing to actually grow legs and walk out. What can we do creatively as a community engagement activity? If you pick one, it can be anything. You can engage in working with a local Latino group and say, you know what, we want to understand this whole process. The local NAACP group. And I think, believe it or not, you'll be better for it because you will understand the depth of the problem in the community. So I think, I don't want to go on too long, but I think that's what I would do.
Thank you. That's very helpful. I really appreciate the suggestion for our leadership team about the diversifying and including members of our community. Doug, I think you may have had a question as well for Dr. Coombs.
Dr. Coombs, thanks so much for that really great presentation. And Lisa, I want to extend my thanks to you for being here to teach us and share your experience with us and share my sorrow and condolences for your loss. Alice, thanks for being here. You've had experience with having these conversations with patients and in your leadership role involved with coaching and mentoring other physicians. So for the people on the call who are involved in having these conversations going forward, what advice would you give people who are in the trenches of doing these apology and open and honest communications? How can they sort of gain awareness, check the biases that you're talking about? How can we how can we prepare ourselves to have these conversations in a better way?
So part of, I think the challenges for mentorship and actually going across silos is really engaging the larger scale. I was at the CHEST convention. I mean, the large medical meetings, I think, are going to be really important for them to have an underlying theme of this is a track that actually looks at healthcare disparities. How we do that in terms of education at the grassroots level, it could either be through the culture that's in healthcare systems, but then you get the isolated docs that are not a part of it. I hate to actually enforce something like a learning requirement for your board registration license renewal, although that would do it, but people would probably seek ways in which they would try to skate on some kind of substitution and not really be attentive to the changes. I think one thing is if you are within healthcare systems, that the healthcare system itself allows an environment for events that happen that are related to patients who are of color or poor patients. This is a case that we should highlight, and we should do a trans, not just with physicians, but all the way across the sports rounds. Oh my God, that is just transformative. I've been involved with a number of them in Massachusetts. I wish that they would do them here in Virginia. That kind of thing actually marries the idea, you're not going to forget Lisa today. Bringing the patient back to have that education. I think for my people that I mentor, I'm constantly giving them a patient. When I was a Medicare Payment Advisory Commissioner in Washington, D.C., and we have all these people, epidemiologists and everyone. It was my goal to put a patient in the center of the table. So when you put the patient in the table and the center, it has stickiness. And I think that's probably going to be, even if you had to do it on a periodic basis, to say, we need, and I think that's what the Swartz rounds do. It doesn't have to go by the Swartz rounds, but putting that kind of thing enforced in healthcare systems and recommending it. And also, I mean, that's one of the things I think that if I was a businessman with a whole lot of money and I was a part of the Leapfrog group, I would say, does this hospital have a patient first initiative? There's money in the bank on that one. Because remember I talked about value proposition? If they have a patient first initiative, and we should call it that, that should be some kind of assessment for Leapfrog criteria to say, we're going to rank you this, U.S. News and Report. I would put it that way so that it becomes a ubiquitous language throughout the landscape where people are saying, oh, have you had a patient first initiative? Doesn't that sound great?
That's wonderful. So we have just a minute or two for anyone else that has a specific question for Dr. Coombs before we wrap up. If you do, just mark that in the chat box now. And Dr. Coombs, just a follow-up to what Doug had asked. In these meetings that all these facilities have with patients when things go wrong, do you have any advice for us if we're having those meetings, types of things that we might be aware of for patients that are of different groups that we're not, that we may have biases or we may not understand the way that we're sort of reflecting our own experience in that. Do you have any tips for us as we meet with these patients to talk about adverse events?
So I think this is a really important thing to do, and it sounds very basic, is ask them about their loved one and give a good 10 to 15 minutes listening to them. Talk about what they were like before. Believe it or not, that marries you to a relationship with that individual. I don't know who you are, and I don't know if I can trust you, but I know that if you listen to me, guess what? That is a step in the door. You just opened the door to my heart, because you took the time to find out. I would also do some research as to where that person comes from in terms of their total experience. It'll be some homework involved in that, but also to be ready to ask questions on the latter part of this presentation was dealing with patient literacy and empowerment. And I don't know if you guys have thought about this, and this is a preventive kind of intervention, is that what do we do to empower students? And I used a Harvard Business Review. You have it, you'll see it in the slides on the latter half. But I think empowering patients is really the essence of addressing a disparity when it exists with a bad outcome, especially.
great. And it's great.
Linda,
advice.
if I can comment 2 seconds.
Sure, yes.
Jeff Catalano, the meeting that Lisa referred to, at which I was at briefly, was a case study on how not to do these meetings. And I'll just talk very briefly about it. You heard the emotion in her voice. It was at the hospital. There were physicians and healthcare providers and risk managers.
Jeff, you could put your video on it.
Okay, thank you. Actually, it won't let me.
Oh, well, anyway, keep talking.
That's okay, sure. So in any event, instantly there was no expression of compassion or apology at all for what was ended up being an understood and obvious mistake that led to his tragic death. And so they're surrounded by folks who are in a very intimidating setting. There was a defensive posture immediately. There was no agenda for the meeting. It was a little haphazard, so no one knew what to say. And again, I'm not trying to demonize everybody because this was 2012, which was long enough ago that this care process hadn't really taken full force throughout many of the hospitals. In any event, it didn't go very well at all. And then, of course, excusing me so they could talk more freely not only was not appropriate because the family was very emotional and needed help just processing what was being said, but of course it made no sense because they're going to talk to me about what was communicated anyway. So it didn't really, and I wasn't turning it into anything where I would be asking questions. I was just going to help them process the information that was being put forward. And then the last thing I want to say is Alice mentioned importantly how biases can lead to irrational decision making. And the important thing about that story about her son is that he entered the hospital, yes, with a swollen tongue, but joking and communicating, and that deteriorated substantially. And Alice helped me to realize the racial biases that impacted the irrational decision-making that took place, because instead of recognizing he needed intubation or an anesthesiologist consult, they gave him antipsychotic medication. And the medical records indicated he was angry and combative. Now, he was a large Black male, and they automatically assumed things about him that were inaccurate. He wasn't being psychotic, he was hallucinating from lack of oxygen to the brain, which wasn't being appreciated. And so that was a new venture for me because even my mind was open during that process. And I just want to, again, thank Alice because she's really heightened all of our consciousnesses, including mine, again, with your excellent.
Thank you, Jeff. Thank you so much.
Hey, thanks everybody for joining and for staying. I'm going to wrap things up here. We had a total of about 170 participants, which is fantastic. So many familiar names on the video, and it's wonderful every year when we can get together and learn together and re-energize for doing this work. And I feel like we've gotten the opportunity now to do it twice this year. So I'm very excited about that. Alice, your presentation was phenomenal and really takes us forward in doing this work that this group has been so dedicated to for so many years. Lisa, if you're still on, thank you so much again for sharing your story and teaching us. And a couple of things come to mind when I think back to today's presentation that I'd like to leave you with. One is patient trust from Melinda sharing information about the effect of open, honest communication after adverse events, and how people who get that are more likely to seek care when they need it, and trust those that give it. And through Alice sharing strategies for reducing healthcare disparities and all of these cultural competency, diverse workforces, linguists, and concordance, she drew a straight line to how improving in those areas will allow us to gain the trust of our patients and allow those people to trust us with their care, as well as trust us after adverse events happen. So I think that just a common theme that we've had throughout the work, and this takes it, I think, forces us to look at it through a new lens. The second piece that so many people are talking about now are the parallels to healthcare disparities and the early patient safety movement. And as I sit here, listen to the stories and understand how hard so many of our healthcare organizations are working to measure and stratify outcomes and understand where healthcare disparities exist and what we can do to eliminate them. It strikes me that we're going to have to redefine what open, honest communication looks like when we identify healthcare disparities associated with adverse events, when we get to the point in this movement when we actually accept responsibility for adverse events that are only there because of biases, structural biases that exist, whether they're racism, sexism, ageism, or other. And I think that's going to force us to continue to learn how do we have these conversations. And that's why I'm so grateful for this group of MACRMI, because I know our work is still relevant, it's still incredibly important, and that we're going to continue to learn together. So I want to thank everybody for joining today, staying a little bit extra, and thanks for a great program. Looking forward to the spring.
Thank you so much, everyone. Have a great day. Thank you.
Thanks, guys.
Thanks, Dr. Coombs.